Good afternoon, everyone. It's 1:30. I'd like to thank all of you for joining us today. My name is Brian Whitlock, and I am the president of the Idaho Hospital Association. As we get started today, I would first like to acknowledge all that is being done by Idaho's community hospitals and health systems to meet what really is an unprecedented healthcare demand across the state of Idaho. On September 6th, crisis standards of care were activated for 10 of the northern counties in Idaho. And today, based on a unanimous recommendation from healthcare professionals on the Crisis Standards of Care Advisory Committee, the Director of Health and Welfare this morning expanded that activation to include the entire state. So what does that mean? First, it means that some of our hospitals, for some of our hospitals, the demands have clearly outstripped their resources. When you have more care that is needed than you have beds, oxygen, supplies, or even staff to accommodate, you may have to do things differently in order to still deliver the best care possible under the extraordinary circumstances that we find ourselves in right now. These are uncharted waters. We have never been in this situation before as a state. Other states have, with hurricanes, earthquakes, or terrorist attacks, but never in Idaho. Activation of crisis standards of care provides guidance for hospitals and those providers who are on the front lines on how to extend care to as many patients as possible and save as many lives as possible, given the circumstances that we are facing. We are joined today by some of our top administrative and clinical leaders across the state to further explain what crisis standards of care activation means and why it was requested. We'll first hear from Chris Roth, who is the president and CEO of the St. Luke's Health System. He will be followed by Dr. Jim Souza and Sandy Gerke, also from St. Luke's. We'll then get an update from St. Alphonsus Health System from Dr. Stephen Emerson. And we will then hear from Tom Murphy with Minidoka Memorial. And I'm going to pause here for just a second.
I didn't think I was going to make it back. I just walked in the door.
Somebody has their microphone not muted. I can tell who it is, but now it's muted. Thank you. Appreciate that. We'll get an update from St. Alphonsus. I mentioned Dr. Stephen Emerson, and then Tom Murphy is the president and CEO of Minidoka Memorial, a critical access hospital in Rupert, Idaho. We'll then wrap it up with Jordan Herget, who is the CEO of Portneuf Medical Center in Pocatello, and he'll share what's happening in the eastern part of our state. We'll then open it up to your questions from the media. When it's time, please raise your virtual hand, and that is in the menu in the center of your screen. If you'll raise your virtual hand by clicking on the button, I will then call on you. When you hear your name, you can unmute yourself. And if you would, please identify yourself, the news organization that you're with, and to whom your question is directed. You can also ask questions in the chat feature. We will be monitoring that if you prefer. And again, just a reminder for all of those that are joining us on the call, and we have quite a number of people who have joined us, please mute yourself and turn off your cameras now. With that, I will turn things over to Chris Roth with St. Alphonsus Health System.
Thanks, Brian. Actually, Chris Roth, President and CEO of St. Luke's Health System. Thank you so much for taking time to join us today. Brian, I want to thank you and the Idaho Hospital Association for hosting today. I also want to provide a few other introductions to the St. Luke's team. So Dr. Jim Souza, who's our Chief Physician Executive, will follow my comments, and then Sandy Gerke, who's our Chief Operating Officer, will follow. We're also joined by Christine Newhoff, who's our Chief Legal Officer, but has been serving as our Public Liaison Officer for the duration of this pandemic, as well as Elizabeth Stager, who is our Chief Nursing Executive. You know, this is an incredibly sad day for St. Luke and for our community. At St. Luke's, we have done absolutely everything possible over the last 20 months to avoid a situation where we'd find ourselves in today of operating under crisis standards of care. Since the beginning of the pandemic, we've prepared, we've planned, we've secured supplies, equipment, beds, space. And I'm so proud of our organization and the effort. I'm also proud of the collective medical community throughout Idaho. The partnership that's been formed over the last 20 months has been incredible, and it continues to this day. We are being overwhelmed with patient volumes today. There are two things that are occurring. First, we're seeing historic levels of traditional patient care. There are a lot of reasons for that, but one of the big ones is we have a lot of pent-up demand from care that was delayed from last year. So normally at this time of the year, we will see lower volumes than typical. We're seeing record historical highs. I've never seen any volumes even close to what we're seeing in my history of St. Luke's with 14 years. Secondly, we are being absolutely crushed by COVID. 2 weeks ago, or at the end of August, we broke a milestone, sadly, of having 173 COVID positive admissions in our hospital. That broke our prior record of 172 back in the December surge. Unlike December, where the health systems raised the alarm, the community rallied, and we were able to stave off crisis standards of care, sadly, that has not occurred in this situation. 2 weeks after we broke that record of 173 COVID positive admissions in our health system, we were at 281. Our projections in early September held true. Actually, our volume slightly exceeded what we thought the projections would be at that time. If we continue on this course over the next several weeks, St. Luke's health system will become a COVID health system. We will consume every single bed and every single resource we have with COVID patients in our hospital. Our ICUs are not only full, they're overflowing. The vast majority of our patients in our intensive care units are COVID positive. 98% of them are unvaccinated. I do want to spend a moment talking about staffing. We have more staff on hand and more clinical staff on hand than we did before this surge, than we did in the middle of the summer. In the last 60 days, we've hired 802 additional support teams and providers. More than half of those, about 450, are clinical providers. In addition, we have 300, actually close to 400 travelers on board today. We've redeployed 300 other caregivers from clinics and ambulatory settings in our hospitals. We have primary care physicians who normally work in the clinics who are providing support in the hospitals. And in addition, we have 170 resources coming to Idaho. Thankful for the state of Idaho and the federal government in providing those clinical teams that will be arriving here shortly. But I can tell you that's not going to be enough staff to support the crushing demand that we're currently seeing. We will do and are doing everything possible to ensure we're providing safe and effective care, but the standard of care is being eroded, and we'll talk a little bit more about that. Finally, I'd like to talk just a little bit about what we can do and what we should be doing as a community. This disease, this pandemic is relentless. We're all tired, we're all exhausted. Sadly, instead of fighting this pandemic together, we seem to be fighting each other. And if we're going to turn the tide, we have to lower the demand. This isn't a staffing issue. This isn't a space issue. It's not a bed issue, but it will be, and it will continue to be, so long as our demand and the pandemic continues to spread around our community. So I would ask all of you who are listening, please continue to do your part, get vaccinated, wear a mask, be socially distant. It worked last year. It helped stave off a potential disaster situation that we find ourselves in now. And with that, I'm going to go ahead and turn it over to Dr. Jim Souza. Jim?
Thank you, Chris. Thanks, everyone, for being with us today. My role is to outline why we made the case that we'd move beyond conventional standards, which is how we usually do things, and beyond contingency standards, which is where we were, which was doing things differently, but still providing the same functional care. Why we had moved beyond that to crisis standards. I want to preface these comments with a little bit of context on what our conventional standards are in the US and here in Idaho, and the good things those standards have brought us. All of us who were trained as healthcare workers in the US were trained with an abundance mentality, and we have very high standards. And as an intensive care doc, I've spent most of my career in one of the settings where that abundance mentality is probably most acutely on display. And what I mean by that is that we've got systems and processes that aren't designed for immediate need or for just in time, they're for just in case. And there's lots of examples of that. I could share those. I'm not going to belabor those here. The point is that our conventional care standards are quite high in the acute care settings of the US and right here in Idaho. We actually have 2 local hospital systems that are recognized by IBM Watson as top 15 in the country. That's St. Alphonsus and St. Luke's. These just-in-case standards are why we often achieve perfect care and high reliability, and those standards are the necessary care elements that allow us, frankly, to carry out the high wire acts that we do every day, like open heart surgery and bone marrow transplants and neurointerventional stroke care and rescue from any number of acute and catastrophic conditions. Those just-in-case standards in acute care medicine in Idaho are the functional equivalent to the net underneath the high wire that allows the high wire act to go on. So the reason we made this case is because the net is gone and the people will fall from the wire. We're not able to continue to provide a conventional care standard. Let me be a little more explicit. We've now stopped surgical procedures that can be reasonably expected to be associated with a significant risk of permanent disability or pathology. We can't measure the impact of this yet, but we will one day. Certain breast cancers and endometrial cancers and prostate cancers and bladder tumors, we will manage medically until we can get to them. We're staffing some of our hospitalist shifts with primary care providers who are amazing in their dedication and teamwork and who are not hospitalists. We're coming around now how best to support them with the acuity of illness that they're not used to caring for. We've given up any efforts to maintain open code beds due to the overflow that Chris talked about, which has led to deteriorations on hospital floors that requires us to do prolonged bag ventilation of patients, squeezing a bag up to hours in some cases, awaiting transfer to an ICU bed, often in a different hospital. We've needed to do the same occasionally due to the lack of a ventilator at a site. We've been using non-invasive ventilation devices that are primitive and have a basic on-off switch with no monitoring or sensing functions. We've begun to routinely ventilate and high-flow oxygenate patients in non-monitored floor settings with those devices. That can lead to alarms not being heard and serious safety events. We've administered vasopressor drugs to artificially support blood pressure via peripheral IVs in the vein instead of a central line for prolonged periods of time in non-ICU sites of care. We've backed off on monitoring of sedation and paralysis in our intensive care units due to lack of equipment and lack of time. We've reduced our vital sign monitoring despite the well-known admonition in healthcare that vitals are vital. We've provided care for sepsis, a bad infection, inclusive of IV fluid challenges, administration of vasopressor drugs, and IV antibiotics in unmonitored settings in emergency department waiting rooms. We've had hypoxemic patients in our waiting rooms for periods in excess of 4 hours. And we've been boarding patients in ED sites of care for far longer than 6 hours, which is known to be associated with worse outcomes. Finally, we've been sending COVID patients home with oxygen and Decadron prescriptions, steroid prescriptions, who would usually be admitted, hoping that their clear instructions and the support systems they have at home will function as their safety net when and if they deteriorate. All of this has led to significant moral injury to our providers and our nurses, all of whom hold themselves to such high standards and are used to providing the award-winning care that I already referred to. So in light of that eroding standard, we made the appeal. And I'd like to turn it here to Sandy Gerke, our Chief Operations Officer, on what actions we've taken and are continuing to take to try to do our best to preserve the standard. Sandy?
Thank you, Dr. Souza. I'm going to talk a little bit about where we find ourselves and the levers that we have begun to pull across the health system in order to care for the unprecedented volumes that we are seeing today, as well as the acuity of those volumes. You heard Chris talk about the influx of healthy hands that we have within the health system. And we have 1,500 more than we had going into the summer. Those are a mix between clinical travelers that we were already looking to secure, that we needed to escalate quicker as a result of the volumes increasing. We have 400 clinical travelers in our health system today. In a typical summer, that would be less than 30. We've also redeployed clinical staff that are non-direct patient care team members. As a result of shutting down the surgical procedures that you heard Dr. Souza talk about, we've taken our surgical RNs, our surgical technicians, our CRNAs, our anesthesia partners, and we've brought them back to the acute care bedside. We've taken our quality and patient safety teams, our managers, and many of our RNs in our ambulatory clinics away from their work to be at the bedside with our other direct care providers. In addition, we've redeployed our non-clinical teams back to the bedside where they can task, where they can help answer alarms, where they can run and grab supplies, and where they can help our environmental services teams turn over rooms and keep things clean from an infection prevention standpoint. We've also stretched our ratios. So a typical RN in an ICU would likely be taking care of a patient on a 1-to-1 basis or a 1-to-2 basis. So 1 nurse to 1 patient or 1 nurse to 2 patients. Today, they're taking about a 1-to-3 assignment. So 1 nurse to 3 patients. We've been able to supplement that with that other help that I just described, but that's still a stretch, especially when these patients are ventilated and proned and on so many different medications. In addition to stretching our healthy hands, and we have had to stretch those, not just because of volumes, but because today we have 400 employees off work due to COVID illnesses. We've tried to stretch our physical spaces. Our inpatient areas are overflowing, as you heard the team talk about. We have opened up 93 additional adult beds within our facilities across the Treasure Valley and the Magic Valley. Boise Hospital has 3 current overflow units. Today, we're working to open up a 4th. Both Meridian and Nampa already have overflow units in addition to discharge lounges. And when we use discharge lounges, that means that as a patient is discharged from medical care, we're moving them out of that bed into a different area of the facility where they can sit and wait for their ride so that we can turn that bed over quicker, so that we can more swiftly accommodate those ED patients that are boarding. Our Magic Valley Hospital has 3 overflow units, and again, today is looking to expand to 4. And while we still have some additional physical space we can take advantage of within our patient care areas, like our surgical areas, our pre-ops, our post-op bays, we are out of actual hospital beds. So every additional overflow area that we start to open now means that our patients are being taken care of on stretchers. And that's not an ideal situation for us or the patient, and actually comes at some additional risks to patient care. We've been leveraging our critical access hospitals across the system. We have our teams from McCall coming down to the Treasure Valley to assist and staff. We've also been transferring emergency department patients that need admitted to our critical access hospitals where they have some staff and some beds available. In addition, our emergency departments are very, very full. We have experienced across the Treasure Valley many of our urgent cares also being at capacity and struggling with staffing in a short labor market. They've had to reduce hours. And when our urgent cares and our primary care locations across the valley reduce hours, it means our patients come to the emergency department. Today, we've opened overflow emergency treatment spaces in our Nampa hospital. We're caring for patients within our imaging suites. So where you might typically have an x-ray done, today we are treating and diagnosing an emergency department patient. We're also today consolidating our outpatient cath lab procedures from Nampa to our Meridian facility so that we can use our cath lab recovery area in the Nampa hospital as a second emergency department treatment space. Our teams are activating on treatment areas within the waiting rooms of all of our emergency departments, so that while not an ideal situation to be taking care of an ED patient in a waiting room, we can at least provide them with some privacy, dignity, as well as the crucial equipment and supplies that our care providers need to take care of those patients. In addition, we've been leveraging virtual technology. You heard Dr. Souza talk about patients going home where they otherwise would have stayed admitted to the hospital. We have what we call remote patient monitoring, and that's intended to help us discharge early, to help us prevent admissions for those lower acuity patients. That service can run about 300 patients on a daily basis. Today, we're running 350, and we have over 30 in the queue waiting to be evaluated and onboarded to that service. We've also leveraged our virtual hospital technology to help be eyes in the skies and an extra set of hands and resources while our nurses are in the rooms gowned up in PPE. We have, unfortunately, had to make plans for overflow areas for our morgues. Each of our hospitals today has an additional morgue overflow working, and we've been partnering with our coroner's offices to increase runs in order to create capacity within our morgues. This week, we're standing up an additional morgue in our Boise facility. We had new space that has come online as a result of our new central plant. Otherwise, we would not have a location to provide for these deceased bodies. I want to also just mention that the strain that we are experiencing from a team member standpoint is heartbreaking. To hear our team talk about the stress that they see and experience when they're working 10 shifts in a row and they don't get to see their family, and they are seeing the death and the despair that COVID is bringing to us. It's really taking a toll across the board. And I'll just close with that. Dr. Nemerson, I know you have comments regarding St. Al's situation, and I will turn it over to you.
Good afternoon, and thank you for all that you're doing at St. Luke's. It's extraordinary to hear the stories of the care that's being delivered throughout the St. Luke's health system. And without going into much detail, St. Alphonsus very much is doing the same. I'll share with you too that we are learning from each other and have been for months. We are participating in a medical operations coordination cell across the state of Idaho that ensures that patients are still getting the right care in the right place at the right time, and yet we find ourselves in crisis standards of care. It's important to understand that that is a state activation, and so it's part of a continuum of the care that we've already been engaged in across the state, throughout each of our facilities, and certainly here at St. Alphonsus. Crisis standards of care are activated when the ability to provide a reasonable community standard of care is exhausted. And that's the state that we find ourselves in right now. Here at St. Alphonsus today, as I speak to you, we have 135 COVID positive inpatients. This is 35% of our total inpatient volume, and we too are experiencing record numbers of non-COVID patients combined with this record of COVID inpatients. Our predictive modeling too shows that this is going to continue unabated, And we may expect within our system, within the next 3 to 4 weeks, a total number of COVID inpatients exceeding 210 at the present progression. And we too are at the maximum capability of providing care without stretching our teams further and further and further. Our hospital census across our system is completely full, and with percentages exceeding 100% consistently. We have over a dozen patients boarding in our emergency departments, and they're not able to get into the regular part of the hospital because we don't have enough beds and we don't have enough staff. When we look at the metrics of COVID spread in our communities, we look at a testing positivity rate of 29% or greater today throughout our system, and greater than 5% is considered a pandemic out of control. This is also the highest positivity rate we've ever seen during the entire pandemic. Active cases of COVID in all of our counties that feed us exceed 300, in some counties greater than 700, and a number greater than 100 is considered severe prevalence. All these things tell us that while it's bad today, it's going to get much worse. And we can expect this to continue for at least the next 2 weeks. And I am scared. I'm scared for all of us, because while we are currently able to tread water and through the mechanisms that St. Luke's has shared with you, continue to deliver a reasonable standard of care, it's going to decline simply because a caregiver can't get to a patient fast enough. With regard to St. Alphonsus, then, we are beginning to make increasingly difficult decisions about how to allocate our resources, and we know that patients are building up, backing up in our emergency departments, our urgent care centers, and that is having a domino effect. Still, we are engaging with in coordination across the entire state, and as best as possible, when patients have completed the bulk of their journey here, we are able to transfer them to lower level of care. At some point that will be exhausted, and basically we're reaching that limit right now. And so with all of this, I just tell you that we are here for all of our patients, all of our communities. It's critically important that people not avoid getting emergency care. It is critically important that if they have a medically necessary or time-sensitive procedure that needs to be performed, they know that we will always be here for them. But we're going to have to start, and are starting, ranking how things are being done. And in the end, if this continues, well, we're not at this point, and to my knowledge, not a single patient in the state of Idaho has been taken off of a life support therapy in order to provide that therapy to another patient that has a better prognosis. While that has yet to occur, if we continue on this path, it will. And my last words to all of us is we have the opportunity to decrease that trend, decrease that progress, but it's going to require rapid and aggressive intervention. And we here at St. Alphonsus are committed to the community to make sure that we provide all that access that's possible to give them that opportunity. And thank you very much for allowing me to participate with you today.
Hi, this is Tom Murphy from Idaho Memorial Hospital. I just was asked to talk a little bit about the impacts that this is having in our rural, smaller hospitals. You know, we have seen in the last 2 weeks, we've seen record volumes in our emergency department. We've seen record amounts of testing, and depending on the day, that ranges anywhere from just under 30% to as high as 40% positivity rate. And we know that those positives today and this week will amount to hospital admissions in 10 to 14 days. Over the last year, due to necessity, we have added 8 more physical beds to our hospital capacity for inpatients. And We've been working for months to be able to staff those. So we have kind of a three-phased approach. Phase one is redeploying our surgical area to become medical treatment area. Our second approach is to take our swing bed unit, which is a much lower acuity, and increase that capacity to be more medical. And then our third phase will be setting up cots in a cafeteria type area. And we're, seeing that we may be just not long from having to set up those cots. At this point, we really depend on our larger tertiary hospitals when we have critical cases that come in. We don't have a cath lab to perform interventions for cardiac situations. We can't do anything about a brain bleed. All of those, in a normal week, we would transfer 5 to 6 patients from our emergency department via life flight or air to a larger tertiary hospital in Twin or Pocatello or Boise, or even sometimes in the Salt Lake City. And we're at a point now where those tertiary centers where we would normally send those cases to are just completely overwhelmed. As you've heard these folks before me, they're doing everything they can. And so our biggest risk factor in a small hospital will be getting somebody in our ED that we cannot get to the level of care that they need. So we are doing everything we can to increase our capacity and help offload some of the volumes from our larger partners around us. We have taken several admissions from other hospitals, including ICU patients, which is not normally the case. We don't normally have a helicopter land here and bring us a patient, but we have experienced that. So it really is coming to roost even in the smaller communities. And, we're at max. Our physical capacity of having a bed for every room is 25. And that can fill up very quickly, as we've seen how quickly this virus spreads and how quickly it makes them so sick. And most of them are needing an ICU bed, and we only have one true ICU where we can intubate, and we do have 4 COVID rooms that we use as isolation rooms. So we're doing all we can to be of help, but we're extremely worried about the future and being able to really get everybody where they need to go for the level of care that they need, and to be able to take care of everybody that's going to need care here. So that's our biggest risk, is in the smaller areas. And I share this risk with many small communities in Idaho. There are lots of critical access hospitals all over the state, and all of us depend on our larger partners to be able to take on that higher level of care. And right now that system is really at risk. And so we're doing all we can to take care of everybody in our community. And again, like Dr. Nemerson, I would encourage anybody that needs emergency care that you continue to seek that, because delaying that care, oftentimes, you end up worse off than if you had just gone in when you really needed to. So we really do want to continue to take care of members of our state and members of our community. And we really want to rally together to try and stave off this wave that just seems to be getting bigger all the time. And with that, I'll turn it over to one of our tertiary center partners in the East, Jordan Herget at Portneuf Medical Center.
Great, thank you, Tom. I just want to echo all the sentiments that have been shared so far today. We want to express our thoughts and prayers to all the communities in Idaho, including the healthcare teams that step up on a daily basis to help us meet our healthcare needs. I see this on a daily basis where teams are showing up 24/7 to provide care that we all need. And it's just an amazing group of people. And I just want to thank and acknowledge those teams that are stepping up to provide that care. It's a tremendous burden that they're carrying at this time. I've been asked to talk a little bit about the situation in Eastern Idaho, and we're monitoring the local and regional situation closely. As has been mentioned, we have daily calls with all the hospitals in the state and with each other. I can tell you that most facilities in Eastern Idaho are running full or to capacity. Like elsewhere in the state, our COVID census is where it was last year in the pandemic, if not much higher. The acuity of patients is high. We continue to act, however, as transfer centers, those of us who are tertiary centers for regional critical access hospital transfers, in addition to helping out where we can with the rest of the state. We're preparing for the continued surge, which may necessitate implementation of crisis standards of care. We have not yet implemented crisis standards of care on the eastern side of the state, and we'll be clear and proactive if it's necessary to do so. We'll be clear in messaging to the community and to the region. And in doing that, we work very closely with our hospital partners across the state, as well as the state Department of Health and Welfare. Again, we part of the benefit of activating crisis standards of care across the state is that we can, if need so, we can do that. We can also create capacity if needed to help our partners across the state. I just want to close with if we do see trends continue like they have and rates continue to go up and so on, we are at risk of implementing crisis standards of care at hospitals on the eastern side of the state. I would echo others who have said that we can get vaccinated, we can wear masks, we can socially distance, we can do hand hygiene. Those are steps that each of us in the state can take to make sure that we have our healthcare system in place in order to meet the needs of the healthcare of the population in the state of Idaho. And with that, I'll turn it back to you, Brian.
Jordan, and to all of our presenters, thank you so much for giving the media, not only here in the state, but I understand we have some regional and national media on as well, monitoring what's happening here in Idaho. We will take your questions now. You can raise your virtual hand, wait until I call your name, and then if you would just manually unmute your microphone, state your name and organization and to whom you are directing your question. Given the number of media that we do have on this call, we would like to just limit it to one question, but we will circle back for follow-up questions, time permitting. So with that, we'll go to the statesman, and Hyatt, I think you were the first one to raise your hand.
Hi, yes, thank you. How many hospitals in Idaho have implemented crisis standards other than St. Luke's? And how close was St. Al's and other hospitals from implementing crisis standards?
Let me take a stab at the first part of that. So as you know, on September 6th, the North region was activated, and 2 hospitals to date have exercised crisis standards of care in the North region. And for St. Luke's, their entire system, I believe, would be included in the request that was submitted. I'll let Chris Roth talk to that, and then Dr. Nemerson, if you would take the question about St. Al's as well.
Yeah, thanks, Brian. I don't have anything to add to what you said. Obviously, we yesterday petitioned the state based on everything we're seeing across our footprint in southern Idaho. All of our facilities are being significantly impacted, albeit in different ways.
Chris, could I just add a comment? I want to make sure folks understand the state's declaration. The state declared that we're in a crisis. We do have crisis standards of care and an activation plan. As Dr. Nemerson pointed out, at this moment, that doesn't mean deallocation of any resource from anyone. What it actually means for us is acknowledging, number one, that the usual standard of care has been breached. And number two, it frees us to continue further innovation, to stretch, to expand, to get more creative, use telehealth more aggressively, further expand care teams, to do our darndest to optimize the standard of care. As Dr. Nemerson pointed out, though, if if this continues, we would find ourselves at a point where decisions like he referenced will become necessary.
Jim, I think you've explained that really well. And speaking for St. Alphonsus Health System, we are at the most extreme of contingency standards. We are in the process of considering a formal notification to the state. We're not required at this point to appeal for activation of crisis standards. That's already taken place. But we're considering a formal notification to the state to tell them that we too are acting in ways that are not consistent with normal community standards. The other thing to realize is that when we talk about crisis standards of care, further down the continuum is a triage process to ration care. And so at St. Alphonsus Health System, we have not been forced to ration care at this point in time, but we do see it on the horizon. And therefore, our triage process has been put on standby. So we have not yet activated that process. And I hope never to have to do that. But that's where we are at St. Al's.
Melissa Davlin, please go ahead with your question.
Thanks, Brian. Melissa Davlin, Idaho Reports. This is probably for Dr. Souza, but I'd love some input from other hospital representatives as well. Dr. Souza, you mentioned that some of the delayed procedures, the non-emergent procedures, will likely result in permanent disability and other adverse effects that we don't know right now. Is there currently a system in place to measure what those adverse outcomes might be, so we do know what the effects have been for non-COVID patients?
Yeah, I mean, if you're referring to cancer cases, I mean, all of those patients are in registries, and yes, we can track that and will. You know, the patients who are subject to this right now do have the lowest risk cancers. So I want to say that. But I also want to say, when you get a cancer diagnosis, like, don't you want it out yesterday? So yeah, we'll be tracking that, and hopefully this period is not a period of time that's longer than a few weeks. And in as much as that's the case, the risk is it's real, but it's small. We want to keep it that way. For context, up north in Kootenai, for at least a couple of weeks, they were only allowing emergent surgeries. Emergent surgeries. That meant all of their open hearts, unless you were actively dying from a heart attack that couldn't be managed in another way, were not happening. That meant brain tumor surgery. Brain tumor surgery was not happening. We're not there yet, and we don't want to go there. Some of those things would be contemplated in the next phases of a surgical rollback. We don't want to go there.
Dr. Nemerson, did you want to weigh in on that as well, or?
Well, happy to do so. I think Jim captured all the issues that we're confronting. We too at St. Alphonsus have now delayed surgeries that we don't consider to be what we call medically necessary, time sensitive. Clearly, what is medically necessary and time sensitive to me as a medical practitioner is different than to you as an individual and a human being suffering with pain on an ongoing basis, or being afraid that that low-level cancer is going to progress in the few days or weeks that you may have to wait. Is not something that I have to worry about. I just have to worry about keeping the place going so I can take care of the patient that has a cancer that is going to spread in that period of time for sure. But that's what we're dealing with. And frankly, that's contributing to the moral injury that our team members are having when in a clinic setting, a doctor has to face a patient and say, I'm sorry, I would have taken it out today, but you're going to have to wait. So that too is weighing very heavily on our team members.
I only want to add into my response that remember the purpose behind this rollback on our next level of cases, which are these yellow cases. It's to repurpose the spaces and the staff to provide care for acutely ill COVID patients. That's the driving force.
Thank you. We'll go to Kyle with the Post Register in Idaho Falls. Kyle?
Thanks, Brian, and thanks all of you for your time. Like many of the reporters on this call, I think we've all been waiting for this day to happen. But when it happens, it feels a lot more real, and it's difficult to understand how we can handle the situation appropriately. Are there any especially dangerous messages that we can share in our reporting that we should avoid?
Kyle, anybody specific that you were directing that to in terms of messaging or?
Oh, no, sorry, just a general question. Thank you.
So just clarify again for me, in terms of how you're reporting on the events of today, how do you avoid something that might make things worse, or referencing things that might make things worse? Or what exactly are you asking?
Yeah, any story framings or any strategies we pursue that might be especially harmful.
Dr. Souza.
Yeah, Brian, I think the only thing that could make things worse is to act like this is not happening, because it most definitely is happening. And we know how to stop it. If you went out and got a vaccine today, it's not going to help us for weeks, but it'd be a start. And until then, wearing a mask when you're in public, not around your immediate family, could help very quickly. So yeah, avoiding crowds, also, good piece of basic advice. I know we sound like broken records, but we've been at this long enough, we can get pretty good with our predictions. You guys, even if the numbers stay flat on the rate of rise that we're seeing in the state, 9,000 of our fellow Idahoans are going to acquire the infection this week. And even if we're generous and we say that in our 50% vaccinated state, that the vaccinated and unvaccinated are as likely to encounter the virus, which I think is generous because I think we tend to see maybe different behaviors in the vaccinated crowd, but let's just say that for argument. And we know that Delta has eroded the efficacy of the vaccine in terms of acquiring infection, but not necessarily in terms of the bad stuff. Out of those 9,000 people, with those generous assumptions, we might actually expect that 3,000 of them are vaccinated. But from our own internal data, and I know Dr. Nemerson's would be the same, where we've got 90+% of our hospitalized patients are unvaccinated, 98% of our ICU patients are unvaccinated. We would predict out of those 3,000 people that 15 of them will need one of our hospital beds. We're very unlikely to need to see them. And 3 of them would need an ICU bed. And sadly, 1 of them might die. In the 6,000 unvaccinated patients, we can expect 300 of those people to need our help in a hospital. And we can expect 60 of them to need our help in an intensive care unit. And sadly, we can expect 24 of them to die. And they are not a statistic. Those are 24 human beings. And I don't know their names today, but some of us around the state will come to know those 24 people's names in the 9,000 that are going to acquire it this week. And we'll hold their hands and we'll care for them and we'll know their families. And they're not a statistic.
Dr. Nemerson?
Yeah, I would like to tag on to that. I think it was a really interesting question. What would be the wrong message to send? And I want to answer that question speaking personally, not on behalf of St. Alphonsus Health System, to say that this is a call to arms for all of us. And when a call to arms is made, there's a lot of emotion and excitement that's generated, and we've seen that today. I've certainly seen it in friends calling me from all over the country asking what the heck's going on in Idaho? How are you doing? How are you going to get through this? And when I've thought about this, the thing that I'm most concerned about in terms of the wrong message is a perversion of the information that we're sharing with you here today, and naysayers suggesting that we've brought this on ourselves as a health system, or we're making the numbers up, or God knows what other kinds of perturbations and misinformation and disinformation can be expected. And so I am very concerned that in the throes of all this emotion and all this information, that some of the public that are hearing this are not going to be able to focus on the immediate needs, which are, first of all, to protect themselves and to protect the people that they love. And second, that they'll be caught up in the flood of data and again, not be able to make sure that if they have a healthcare need, they come to a healthcare provider today because we're still here for them, or they'll be further misled to think that they can't trust us more than they already don't trust us. And that's part of what's been going on here as we talk about this division in the country, is half the country doesn't trust the greatest healthcare system that's ever been created on earth, with hundreds of thousands of people across this country working feverishly every day just to take care of everything from bloody nose to the most serious of injuries. And so that's what I'm worried about. And I hope you all can help me to send the right message, which is we're here for you. We're going to be here for you no matter how badly this gets. And that it is likely to get bad, but we will all do the best we can to get through it, and we will get through it.
Brian, if I could add just a couple more things. I think that's an excellent question. And I think, you know, we talk around here about if you're getting all your information about COVID from social media, you're probably getting it from the wrong place. And there are a lot of misleading information out there that I think if you could in the media portray, let's trust our local healthcare providers. Let's trust our physicians that we've known for years. Let's trust our local hospitals that have been taking care of us for years. Let's trust our health officials that really are vetting some of the information that's out there and providing good, truthful information and data to everybody. I think if we can get that message out there, that more than trusting something just off the wall that you read on a social media outlet, let's trust our local healthcare professionals and physicians. We 100% of our physicians in our organization are immunized because they know how dangerous this disease is, and we've seen firsthand what it does to people. It's an awful, lonely, and terrible hospital stay, and if it's a death, it's an awful, lonely death as well. So I thank you for bringing that up from the Post Register, and I think if anything, let's get the word out that there are reliable sources of good information, and there are unreliable sources of information as well.
Thank you, Tom. Jack Schemmel, you're next in the queue.
Jack Schemmel with KMBT in Twin Falls. This is just for Tom really quick. I missed the first part of when he was speaking earlier. And I know we've talked about which hospitals are enacting crisis standards of care right now. Tom, are you guys still not there yet in Minidoka Memorial?
Yeah, we are in contingency mode, I think would best describe where we're at, because we've redeployed some spaces to be medical spaces. And we're doing okay. I mean, the water line's right here, and we just keep trying to keep our head above the water. And we're trying to do what we can to offload the larger hospitals to the east and west of us, so that they can take our more critical cases and we can take their cases that we can handle here. But I'm extremely nervous, like I said, with the amount of ER visits we're seeing that are record numbers, with the amount of testing that we're seeing that are record numbers, and the high positivity rate. We're really concerned that we'll be overrun before too long as well, because, it's like Dr. Souza said, you can track this data pretty reliably now, that when you have lots of positive COVID tests, 10 to 14 days post that, you have lots of hospitalizations that come as well. So right now we are managing and doing what we can to be ready for higher capacities. So that's where we are today.
Thanks, Tom. Joe Paris, KTVB.
Thank you so much. I know, I guess on September 7th, in North Idaho, we saw the crisis standards of care implemented up there. And a question that I saw asked of Dr. Scoggins at Kootenai Health was about field hospitals and resources. And I remember the conversation at the time was around, well, even if we do get to the point of needing field hospitals, we don't have the resources, we don't have the staff to help people that would be in a field hospital anyway. My question for Treasure Valley Hospital leaders, I guess for Southwest Idaho, at this point, are we more concerned about physical space, and would a field hospital be something that was explored? Or is it like the situation in North Idaho where there's more concern about resources in terms of people to treat other people, or resources like ventilators?
Yeah, Brian, this is Chris Roth. I can speak to that, and then maybe Sandy Gerke can add on. Last year in 2020, we did look into the option of a field hospital, and at the time we didn't feel it was necessary. We have that as part of our contingency plans and work with the state and state resources around that area. As Sandy mentioned earlier, at St. Luke's, we have additional facilities and space. We have not opened up conference rooms or untraditional areas of care. So we would first maximize all of those resources that we have. And setting up a field hospital is the easy part. Finding the medical workers to staff that is much more difficult. Sandy, do you have anything to add to that? And Sandy, you're on mute if you are speaking.
I'm not sure if she had to step away or what, but
I probably covered it, Brian. I don't know if others have anything to add.
it was eloquent. Yeah, you covered it completely. Thank you. All right, let's go to Rachel Cohen with Boise State Public Radio.
Hi, this is Rachel Cohen with Boise State Public Radio. I was wondering, at this point, is there any relief Idaho can get from neighboring states in terms of hospital capacity? Are there any conversations happening, with hospitals in other states? And if so, which ones?
Why don't I ask Jordan maybe to take a shot at that, given his proximity to Wyoming and Utah and some of the conversations that have gone cross-border there. Jordan, can you field that one?
Yeah, I'm happy to, Brian. That's a tough question. We always try to keep patients as close as we can, and You know, in recent days, we here have looked to hospitals in Salt Lake and in Utah, which is oftentimes a relief valve for us that we can transfer patients down to. And frankly, they're full as well. They have very few ICU beds, both with their big system, Intermountain Healthcare and the University of Utah. So unfortunately, that option is kind of diminished. I think everywhere neighboring states are kind of in the same boat.
Thank you, Jordan. Anybody else want to chime in on that? Okay, Kyle Land, would you let us know who you're with and who you'd like to ask a question of?
Hi, this is Kyle Land from the Idaho Statesman. My feed cut out, so I don't know if this question was asked earlier, but I mean, state leaders have said for most of this pandemic that strain of healthcare systems was the #1 concern. But now we're here at crisis standards of care, and the state has no mask mandates, no public gathering limits. And I know the governor has said he might try to resist a federal vaccine mandate that President Biden issued last week. I'm sort of wondering from hospital leaders what these types of actions or inactions have had an effect on the current state that we see hospitals in right now in Idaho.
This is Chris Roth. I can maybe start us. You know, I think one of the themes that you've all heard today is we need everybody to do their part to protect themselves and one another, and we need to fight the pandemic together. There is so much misinformation and opinion and division that is out there. If we could rewind the clock and talk about prior decisions from the governor, school districts, or others, you know, it's interesting hypothetical exercise, but where we are today, you know, we've seen with mandates, many people choose to dig in, not suggesting that they don't work and they haven't been effective in the past. I highlighted earlier in my initial comments that back in our surge in December, the Idaho community rallied and people made their individual choices to do their part. And that's just not happening. To the prior question relative to surrounding states, I know the state of Washington has a vaccine rate that's at least 20% higher than Idaho. Eastern Washington is starting to also become overwhelmed, primarily as a result of Idaho residents who are not able to get care in northern Idaho. We're seeing the same things occurring in Utah. They have a lower vaccination rate. So I'm not going to opine on, you know, what the politicians or what the governor should do, but everything that advances vaccination rates, safe activities, gatherings, anything that we can do to encourage people to wear masks, we support that, and we have from the beginning.
Thank you, Chris. We are just a few minutes past 2:30. I'm going to ask our presenters if they would hang on for just a couple of minutes more. Hyatt, I do have you in the queue, but I want to open it up to anybody else for a first question before we go to follow-ups. Anybody else with a question for our presenters today? Okay, Hyatt, go ahead with your follow-up.
Hi, thank you. Yeah, this is kind of a follow-up to Kyle's question. The messaging has at the state level has been pretty consistent to get vaccinated, and this might be a question for Dr. Souza, like you said, Dr. Souza, that's not going to help for a couple weeks. I'm interested to hear from rural folks too. Are public health officials advocating for stricter restrictions like limiting large gatherings, either at the state or local level? Is that something that healthcare providers would actually find helpful right now?
Dr. Souza?
I am trying to turn, hey there, I'm having connectivity issues. I'm going to sound like a broken record. The same practices that we've been asking for throughout, especially when disease transmission is so high and positivity rates are so high, are prudent, limiting gathering sizes, wearing masks, being outdoors more than indoors, getting a vaccine. We don't make public policy. Would we support those things? Sure, absolutely. It's part of the reason that all of healthcare have those policies inside of our businesses, is because we know what it takes to keep the lights on in our businesses. You heard that we have 400 staff out with, COVID related illness. That is a driving force behind our own internal policies around vaccines.
Thanks. I understand John O'Connell, you may have your hand raised. It's not showing up on mine, but if you'll unmute and ask your question.
Yeah, thank you. I have a question for Jordan from PMC. You mentioned that we hadn't reached a crisis level of care in eastern Idaho or southeast Idaho. I wondered how close we are and if we'd had to delay surgeries yet for any patients, and how things might be different than normal right now, even though we're not there yet.
Yeah, great question, John. Just as Tom spoke from Minidoka and some of the other presenters as well, we have been in contingency standards of care and utilizing that in certain cases. So on a day-to-day basis, we'll look at our surgery schedule, and in some cases, those surgeries have been delayed, moved to another day, moved to the next week, and so on. So that is definitely having an impact on the health of the population, because those are, even though they're sometimes non-emergent cases, mostly non-emergent cases, they do impact the health of folks. So that is one example of a contingency standard that we're operating under. And we look at, things like our COVID census, we look at our ICU census, ventilator usage, and so on. Right now, we're fortunately in a situation where we're not at crisis standards of care, but as we mentioned, if trends continue and things go down the road they're going, we're at risk from moving to that pretty quickly.
Thanks, Jordan. Kyle, follow-up question? Kyle Land?
Yes, thank you. Yeah, I'm just curious, with events coming up like a Boise State football game that's expected to have 36,000 people and Tree Fort Festival, these events, which have a high risk of injury or just other types of illnesses unrelated to COVID-19, is it safe to have these events, and what's the risk to the health system to allow these to continue at full capacity?
I'll be happy to take that, Dr. Emerson St. Alphonsus. The short answer is no, it's not safe to have those events, but we don't know that we can change the trajectory. The best thing would be if people are going to attend those events that they cover their faces and stay separate, but we've seen that doesn't happen. But I think what we need to do collectively is also start to change the conversation, because recognizing that half the country isn't going to change their minds about this, we need to start speaking to the half the country that is responsible and wants to protect themselves. And so people can select not to attend those events, even with a mask. And people can also select to frequent businesses that practice COVID-safe behaviors. Going out to eat in a restaurant that has an open patio as opposed to indoors, and that is still maintaining the distance of the tables, that's a restaurant that is safe to attend, and one that also has its staff covered as far as their faces are concerned. And similarly, I think that parents who want to protect their children and who have been responsible, they're getting their 12-year-olds vaccinated and they're worried about their 6-year-olds. Those parents should be demanding of school administration that something be done in the building to keep everybody's face covered. And we've not seen strong movements. And, I think there's tremendous opportunity to change collective behavior through those kinds of efforts.
Joe Paris, final follow-up question for us this afternoon.
Thank you so much. I know that a storyline over the last, I guess, 6 months has been that ICUs and hospitals were beginning to fill up with a large amount of unvaccinated patients. And I'm curious for some insight from our hospital leaders about the conversations that are going on with unvaccinated patients. Are they there because of misinformation? Are they there because they simply just never looked into getting a vaccine? And can you explain to people at home like how this wears on frontline healthcare workers continuing to have these conversations with people who I've been told are arguing with ICU staff as they're being intubated, saying that they've been poisoned and that COVID's still a hoax?
Let's let our clinical folks, Dr. Nemerson and Dr. Souza, tackle that one.
Yeah, I'll share that what the cause for those folks being led off the cliff is the misinformation that they're consuming. So I direct my my frustration not toward the misinformed, but the people who give them the misinformation. And you know, it's sometimes it's, I'm going to say oftentimes, on social media and in other forums, it's people who share the credentials that Dr. Nemerson and I do, maybe dress up with a white coat and take a piece of information and then create a big, long line of causation and factoid information around it. And it plays to people's confirmation bias. And that confirmation bias is that we're all tired of this. We all want it to be gone. But just because someone says it's not important and it's not a big deal and nothing bad is going on, doesn't mean that any of that is true. And you know, our frontline staff are confronted with that sentiment. That largely the biggest thing we hear is, "I didn't think this would happen to me." And that is sad. When you have to explain and when you get the question, if my husband, if my wife, if my son, if my daughter had been vaccinated, would this have happened? And the answer, of course, is no, it would not have. Steve, I don't know what you'd add to that.
It all comes down to the story. It all comes down to the one patient. And so let me tell you this story. We had a pregnant woman in our intensive care unit who came in COVID positive, became critically ill. I will jump to the punchline, which is thank goodness we were able to save her life, but it was a dicey proposition and she almost died. And the words to one of our caregivers was, "I didn't get the vaccine because I was trying to protect my baby." I'd try and protect my baby too at all expense. But why didn't she know that getting the vaccine reduces the risk of coming into the hospital, reduces the risk of ending up in the intensive care unit, reduces the risk of death, reduces the risk of preterm birth, and increases the probability of having a healthier, safer pregnancy where her baby is going to have better developmental probabilities and do far better? That's madness.
Thank you, Dr. Nemerson, Dr. Souza, Chris Roth, and Sandy Gerke from St. Luke's. We appreciate Tom Murphy from Minidoka Memorial, as well as Jordan Herget from Portneuf Medical Center, helping give some statewide perspective to today's announcement. This is not anything that any of us wanted. In fact, there are all of these folks that have worked tirelessly over the last many months to prevent this day from happening, but it has. And we wanted to give the media and the people of Idaho an understanding of what it means, the work that continues, even with this activation that has taken place. And even though the Department of Health and Welfare has activated crisis standards of care statewide, there are still hospitals that will only implement that as needed and according to their own crisis standards of care policies in their hospitals. All hospitals are not moving to crisis standards of care today. If they are managing under their current circumstances, they can continue to do so. What crisis standards of care activation does allow them to do, though, is to follow some guidelines that will help them to determine how to most effectively use scarce resources that are becoming even more scarce because of the increasing demand and the increasing number of COVID positive patients that are seeking care in our hospitals throughout the state. So thank you to the media for helping explain what crisis standards of care means to the people of Idaho, and hopefully encouraging them to do their part individually to help us out of this crisis moving forward. So thank you to all for participating. We appreciate those who have presented as well and taken the time to help add and shed some additional light to today's announcement. With that, we'll go ahead and conclude today's media availability.